session of Living Well with Adena. I'm Dr. John Gabus, the Medical Director of Community Partnerships. And we're talking today, in October, the month that's focused on breast health, we're talking today about breast health and breast cancer screenings. During COVID, many people put off their routine screenings, and that could have a serious harm to you. We want to be sure that we put your mind at ease, that it's very safe to come out and get your screening mammograms. And we'll talk about the various ways and various locations you can get that accomplished. Joining us today are Dr. Rebecca Pereja, nurse midwife Rebecca Soroyan, and not a Rebecca, but Kendra Pollard, who is our breast health navigator in imaging. So welcome, and so glad that you're here.
Yes.
And this is, we all have women in our lives. If we're not women ourselves, we have women in our lives that are so very, very important to us, and we want the best for them. So this is something we want to encourage all of our viewers to be sure that you pay attention to. And remember, if you have any questions, please put them in the comments or the chat section of the live stream. So, Dr. Pereja, how did you end up in women's health?
Women's health, I guess it just really called to me when I was in training. Initially, I was really into sports medicine and doing all that kind of stuff, but I really liked my surgical rotation on OB, and I fell in love with just working with women, and women are great. So I just stuck with it, and I'm really, really happy that I did.
Good.
Yes,
Terrific.
Yes.
And Rebecca, how did you get interested in women's health?
Kind of similar. I started out my nursing career in emergency medicine and had a couple of OB obstetrical patients come through the ER and felt really drawn to them, and like I wanted to learn more and help take care of them, and that between that and some personal life experiences, moved on to labor and delivery and eventually became a midwife.
Terrific. Terrific. And Kendra, how did you end up in your role?
I started as a radiologic technologist and started Adena about 16 years ago, and had an opportunity with mammography, and I had a great aunt with breast cancer, so that was very close to my heart, and I pursued that and have been doing patient navigation as well for the past 7 or 8 years here at Adena.
Terrific. I recall several years ago, before we redesigned the process, a woman would get a mammogram, and if there was something abnormal, there wouldn't be any follow-up for over 6 weeks or longer. And I know that today that's not the case, thanks to navigation and thanks to ready access to mammograms. So let's start out by saying, what is the first thing a woman can do to help herself detect breast cancer early?
I'll start. It's more of a self breast awareness versus like examination, right? Just kind of being aware of your breast tissue, aware of the symmetry of any lumps or bumps that there may be, any discharge or blood or things like that, pain, right? So it's very much of an awareness of your body versus palpating if you're someone who isn't really high risk, right? You don't have a family history of any kind of genetic BRCA or just history of breast cancer yourself or a mom or aunt or whatever. That's one way to kind of help, not necessarily prevent, but possibly catch it early. And that's just everyone in general. Screening mammographies are the number one way that we go. And that really depends upon age and obviously risk factors of the patient as to when that starts.
Okay. Rebecca, Rebecca Soroyan, besides family history of breast cancer, what are some other risk factors for breast cancer?
So there's risk factors that you can change and cannot change. Things that you can't change would be, like you already mentioned, family history, carrying the BRCA gene would be a risk factor. Things that you can change would be obesity, smoking, drinking, all these things, drinking in excess, all these things put you at higher risk for developing breast cancer. Having dense breasts as well can be a risk factor. That's something that obviously you can't change.
Okay. So self-awareness and self-exam for women, and being aware of those telltale signs, but also being concerned if there's something a little different that you've detected. So we would order a mammogram. So wait, let me think. Do we need an order for a mammogram any longer at Adena?
So technically, no. It can be like a self-referral process, just based upon you meeting the requirement of age. So no, and I know Kendra knows way more about that whole process just from the navigation side. But just going back real quick on the self-breast exam. So it's such a misconception, because that's something that we always like preached for years and years and years, is the examination. But studies have found that women who are average risk and don't have any of the major risk factors, a self-breast exam is actually not recommended. It's the awareness term that they use instead, because more false positives are found, anxiety is increased, patients come in and they're finding women who do self-breast exams don't find cancer any more than a screening mammogram does, right?
Thank you for clarifying that.
So it's a huge, so we try to change the terminology to the awareness part versus the actual examination part. And if you are at higher risk, then I will teach you the appropriate way to do an exam, because a lot of women don't know that either, and they're not comfortable with it, right? But yeah, that's a common, and we've all made that mistake, because it changes.
Right.
Science changes.
Right.
But, so yeah.
Yeah, so evidence has changed the way that we approach things. Similar to a man for a rectal exam for prostate cancer detection. It's not any better than a PSA over time.
Wild.
So that's true.
Yep, for sure.
Okay.
Yeah, but for the self-requesting process, that is something that, if you are of age, if you're at 40, and you're established with your provider, you can go ahead and call scheduling, make your appointment for your mammogram. We'll copy results to your provider. Results go to you directly, but yeah, if you're 40 over, you can definitely have your screening exam completed. If you have any concerns, if you've done your exams, have any concerns of your breast, we definitely want you to take that to your doctor so they can order the appropriate testing for a diagnostic evaluation.
Okay. So say there's a screening mammogram done. Are there different techniques for a screening mammogram that some are more sensitive than others?
I think we've come a long way from the traditional mammogram, the 2D, right? And that's when they're just, so a mammogram is an X-ray, right? And there is certain radiation exposure, not minimal, but there is some to that. And the difference between a traditional and a digital is just that the digital ones can be uploaded to a computer. So you can kind of change a little bit the filtering of it being lighter or darker to see certain calcifications, or zoom in versus zoom out, or typical X-ray we used to see in the movies, or when we were younger, if we were old enough to see those, they would just put them up in the light and you just look at it, right? And that's all you got. So now it's kind of progressed from just this two-dimensional image to like a three-dimensional image. Still an X-ray, more images, a little more radiation, but they're able to get views that normally would be obstructed, as you know, just having the 2D view. So for the most part, my understanding is that we were only, thankfully at Adena, only doing 3D. And it's called tomosynthesis, but it's still just 3D mammogram.
Okay, so good. So we are using the current technology
For sure.
here at Adena, and any Adena site has this technology?
Yeah, 3D is offered at all of our locations. We have our mobile unit, which will go anywhere throughout the community where there's a need and a request. But standardly, we have Jackson, Waverly, Greenfield, Western Avenue, and here at our main site. And 3D is definitely a standard at all of our imaging sites.
Terrific, good, so good. So here's one of the things that I'd like to step through is step by step. I'm a woman, I've gotten a screening mammogram, and we'll talk about the schedule for those in just a bit. But I get a call back from my provider saying, there's something not exactly right about your mammogram, we need to do more testing. What's the next step after that?
I initiate that phone call. I initiate that phone call to patients. The first part of my navigation begins at those callbacks for additional views. When our radiologists see something that they want more pictures of, I get in communication with the provider, make sure we have the appropriate orders, and then call the patient to review those recommendations. Because as you can imagine, the anxiety from that phone call is very difficult. A lot of times women are at work. They could be shopping at Walmart when they're getting this phone call, or driving. So timing it is always the first goal. Just to make sure that they're at a time where they can go over the information. But that starts from reviewing that finding by phone, making sure the patient understands what the recommendation is, and then to schedule that at a convenient time. You were mentioning before that it was a 6-week time frame. Typically within 1 to 2 weeks at this point, we can get patients in for that diagnostic evaluation. A lot of times it does correlate with the breast ultrasound, because ultrasound is another great technology If we can focus on one specific abnormality or area of interest, the diagnostic mammogram, utilizing that 3D spot compression on a specific area, along with the ultrasound, can help us to get the radiologist some more information if there's something there where biopsy is indicated. Again, that's where I step in to kind of go over patients' results and information and help to coordinate that.
Yeah, I can only imagine the anxiety and the concern when somebody calls and says your mammogram was
Yes.
abnormal. How often in follow-up, after you have an abnormal mammogram and there's follow-up, how often does that turn out to need further evaluation or a biopsy?
80% of our callbacks are just normal benign findings. You know, that we have things that develop in our breast tissue normally that have no concern of cancer. It could just be cystic finding. Dense tissue does sometimes change for normal reasons. There's benign calcifications that do sometimes develop. So our radiologists, the goal for them is to get the best possible images that we can for them to have that information, and then to know from those additional views if a biopsy is indicated or if it is benign. We do sometimes follow areas just to confirm stability. Malignancies will grow and tend to increase in size or shape. So if there's stability, or even if it goes away in 6 months, then we wouldn't have to do any additional biopsies or additional care from there.
Mm-hmm. So what is the role of the radiologist? So if a woman is getting a screening mammogram and it's an abnormal, or the technologist sees something that's unusual, does the radiologist get involved?
The radiologist is always involved with diagnostics. Screenings, they read at a later time. But with those diagnostics, and that's kind of why it takes so long to get in, because it's a very interactive test. Our technologist will start with that report from the radiologist and perform those additional views, and then take them directly to the radiologist for review. They'll let us know if they need additional imaging, if they do need a breast ultrasound, and then that also includes a consultation where the radiologist will come and talk with the patient directly. All of our diagnostics get their results the very same day. So again, we were talking about patients' anxiety. It's a high concern for us, and we want to make that, a lot of times, like I said, the additional views are benign. We want patients to have that information that day, and not have to wait for results to come back through their online portal, or to see the results, get it in the mail through their provider. So we do give all diagnostics results immediately by the radiologist.
Okay, so as we talked about before, there's a schedule or a recommended time to start screening mammograms. Dr. Perezia, can you talk about that schedule?
For screening mammograms or
Yes.
for breast exams?
Screening breast
Screening
mammograms.
Mammograms. Okay,
Yep.
so there are so many different, not necessarily committees, but colleges and foundations and societies that recommend, unfortunately, different things, and there's not like one perfect answer. So for ACOG, American College of Obstetrics and Gynecology, we start at 40, and it's recommended every year until the age of 75. After 75, it's kind of a patient-doctor discussion, because as you increase in age, the risk of breast cancer increases, but if they're of average risk and have no family history or no personal history at that point in time, they can opt out of doing it. My personal opinion is a little bit different, but it kind of depends on what the patient wants to do. After the age of 55, because we've moved more toward 3D, even though discomfort with a mammogram hasn't necessarily changed with 3D versus 2D imaging, it's more radiation that the breast is actually getting. So is it acceptable to do every 2 years, or every other year? It is acceptable based upon the patient. So it's patient by patient basis. But hard, fast rule for ACOG, it's annually every year starting at 40. But again, with different societies, American Cancer Foundation pulling in, just like it changes, right?
Right.
So we start at 40 and we recommend it every year. Depending upon their history, are we a little more lenient to being every 2 years with those who are very, very low risk? Yes, just because we know we're all getting 3D at this point, or at least our locations are. So we're kind of, it's a kind of catch-22 with radiation versus just catching
The risk and benefit.
Yeah, exactly. And as long as patients are aware that there's a risk that by us skipping a year, something could be happening, right? Most patients are okay with that, or they're like, no, I'll just do it every year, it's fine.
Mm-hmm.
So it's way more of an interactive discussion with the physician and patient, or provider and patient.
Yeah, I've had some of those discussions with elderly patients that I care for who have never had an abnormal mammogram, who don't have a family history of breast cancer, who don't have any changes that they've noticed in their breasts. Then we discuss whether it's annually, whether it's 2 to 3 years, what are they comfortable with, and what would they want, with them understanding, cancers can develop in between those times.
Yep, for
Right.
sure.
So we've talked about increased risks of breast cancer, family history being one of them. But if I recall, most breast cancers don't have a family history. They occur kind of sporadically without those
Spontaneously.
increased risks. Is that something that you found, Rebecca?
Yes, so even with the genetics that we have, genetic testing in terms of the BRCA analysis, looking for that BRCA gene.
Could you speak at the end of this? Could you describe what you're talking about, the BRCA
Sure.
gene?
Yep. We still find that, I believe it's less than 20% of breast cancers. Is that accurate?
So I think it's less than 5% of breast cancers are related to the BRCA gene.
Yes.
It's crazy.
Yes.
Wild.
Yeah, so less than 5, and then even expanding on that, with family history, it's not a guarantee that just because your mother, your grandmother, aunt, sister had breast cancer, that you yourself will develop breast cancer. They do develop more sporadically and kind of a lot of times for unknown reasons. And the BRCA analysis that I was talking about is a genetic test that Adena does offer, looking for the BRCA gene, which has been linked to breast cancer and other types of cancer.
Okay.
So it's a blood test that patients can have done to look and see if they carry that gene.
Okay. So everybody is aware of the Susan Komen Foundation and the Stephanie Spielberg Foundation at OSU. I'm wearing a pink shirt for Breast Health
It's
Month.
great.
Kendra's face mask is pink.
There's ours. Not very nice.
So the awareness of breast health is the key. What have you seen over the course of time with COVID? People are aware, but they've declined. The number of people getting screenings has declined. What have you noticed in your practices, and are there steps that you're taking to get people, quote unquote, caught up on screenings?
I think it's not just with like screenings for like mammography. It's like colorectal screening. It's
Every
all screenings in
screening.
general. And you think of screening, you think of optional, you think of non-emergent, you think of can wait. So once COVID hit, that was definitely put on the back burner for most people because they're like, I don't want to be anywhere where there's other people that could be. We shouldn't know enough, about COVID, and the preparatory or have vaccines and things like that. So I would say that we've all noticed, maybe not necessarily a rise of cancer now. It's just we're catching up to people who haven't had any imaging, and that's not just, again, the breast. I think we're all just finding an influx now that everyone's coming back, we're getting our screenings done, and we're like, oops, right? We caught something that maybe we would have caught the year before, maybe not, right? Totally depends. So I definitely noticed that kind of a change, but I feel like we're doing a lot. This talk helps. But we've had the mobile unit at our office, I'm sure, at your office too, and they, and I think you go out too with the mobile unit, not the breast screening one, but we have a mobile unit anyway. But we have one that kind of travels around, so we're trying to be as accessible as possible to people and get the information out there.
So I want to remind our viewers, if you have questions or comments, please put those into the chat or the comments section of your live stream, and we'll get to those as soon as we can. So with colon cancer, I know the screening recommendation dropped 5 years because younger people are getting diagnosed with colon cancer sooner. Are you seeing a similar trend in women with breast cancer or other female cancers?
I think with breast cancer specifically, no studies have found doing less than 40 for average risk, 35 it changes for like we're talking about with the BRCA gene, increased risk of breast cancer, ovarian cancer, things like that. Those patients get different screening. They meet different criteria. So we do things earlier with them than we would with your typical person. So as of right now, ACOG has not changed any recommendations to start going to 35. I noticed when I came, Some practitioners were starting between the age of 35 and 40 to get like a baseline mammogram, and the insurances were covering that, so that you knew like at 36 you had this cystic benign lesion, so at 40 don't freak out about it. But at the same time, it's kind of like, are you not going to still follow up on that at 35? You are. So then it just didn't make much sense. And so we've never approved that. I've noticed that. I've kind of looked into it, and I don't know where that started, but like, stop doing that, right? It's 40 for screening. We're not doing it any sooner unless you have a patient that has risk factors that meet criteria.
Or
to do it.
symptoms or issues
100%.
that
100%.
need that.
And then it wouldn't be screening, right? It'd be
Right.
diagnostic.
Right.
So, for sure.
Okay. So we've talked about 2D mammography, 3D mammography, ultrasound. What role does advanced imaging play in detecting or screening for breast cancer? Say, is there a role for a CAT scan? Is there a role for MRI?
CAT scan can detect breast cancer, but unfortunately those situations do come to us in a very late stage. So we have a lot of situations. I can think of multiple patients right now, which I'm sure you guys see a lot of times too, but elderly women who have not had their mammogram for a very long time, have been the caregiver for their husband or someone dear to them that they've neglected doing their testing for so long, knew they had a palpable mass but really didn't address it because they knew they didn't have the time, didn't want to even start the mammogram because they knew they need a biopsy and knew they would need some treatment and surgery. So those CAT scans do pick up those late stage. CAT scan is not going to help with detecting something of an earlier stage. That's our focus is definitely towards early detection. We want to be able to find something when it's at its earliest stages, and to identify something as small as a calcium deposit on a mammogram where it's a stage 0 or stage 1. I mean, that's our goal. We want to find something when it's going to be easier to treat, not going to be as invasive and including lymph node involvement. So that's where the mammograms are always going to be the standard tool. You have that 3D mammogram, which will help with finding it at its earliest stages. Breast ultrasound is also a great tool. Ultrasound can help with evaluating specific areas of interest when identified by a radiologist, when found by a patient, sometimes even used as a tool for dense tissue. But breast MRIs would be the third imaging tool that's used very commonly in detecting breast cancer. And those situations for breast MRI would include if there's been a breast cancer diagnosis, a breast MRI can help with evaluating the extent of a disease. An MRI can detect things higher into the axillary region, to the chest wall, find things that may not have been seen through dense tissue. They use a contrast with breast MRI, so that's something that can be evaluated. If you have dense tissue, you can utilize breast MRI along with your mammograms. And then with implant imaging, sometimes they recommend those along with your mammograms.
Okay, so it's kind of case specific for where MRI becomes valuable.
Yeah, breast MRI is not a standard screening tool for breast cancer.
Okay, all right, thank you. That helps to clarify. We talked about risk reduction, and I'm thinking of risk reduction for an abnormal mammogram. So fibrocystic breast changes can trigger a diagnostic mammogram. Sure. What are some of the things that women can do to decrease the progression of fibrocystic disease or the symptomatic component of fibrocystic breast changes?
Do you want to go? Do you want me to go?
Go ahead.
Go ahead. I hate to be the one to keep talking.
That's all right.
So fibrocystic changes in the breast, you can't really prevent that necessarily. It's just with patients who have that type of disease, not a disease, it's very common, tends to get worse around their menses. And so again, the awareness part, like be aware, like if you notice you have these like little cystic changes or just little fibrous tissue that comes around your period and then goes away, and then comes back and goes away, and it's related, very cyclical, I'm okay with that based upon their history, right? I was like, but if it comes and it stays and it's not symmetrical and it feels different, you come in. So hormonally, can it be treated? Maybe, right? Contraceptive pills may help that. It just really depends upon the patient and the cause. So there's really nothing you can do to prevent that. It's just kind of like, it just is what it is.
So caffeine, does caffeine impact
Certain
symptomatic?
Women, right?
Yeah.
Some will say, some say caffeine definitely can do that, yeah. But not all women have that kind of an effect. So it's kind of definitely very specific, right?
Yeah, and there's not necessarily a recommendation to decrease caffeine consumption related to fibrocystic breasts. It's just kind of one of those things that you let women know, like this could be also a cause of why this is happening, why you're having these little cysts.
Or pain.
Or pain.
So as we get towards the end of our time, is there anything that we haven't discussed or brought up that you want our viewers to be aware of? I think we've covered a fair amount.
Covered a lot.
I think mammography in general, of how much it's evolved over the years. Technology for me has changed 3 times since I started in mammography, and the way that the machine is designed, the way that the images are developed, really everything about the mammogram has changed, and it's so much more comfortable now for patients to have mammograms, just simply the way the machine is shaped. Initially, mammograms, universally, the edge of the machine was at a complete 90-degree angle. And every time we would position those side profile images, patients would say, oh my gosh, that just pokes right into my arm.
Hurts.
It's uncomfortable.
Yeah.
And now the machines are completely redesigned to where there's a curvature to it. So when they're lying their arm for that axillary view, we're looking deep into the chest wall. When we position patients, it's just so much more comfortable than what it used to be. We can adjust even the actual compression that has a flexibility to it now. So once we compress you with this technology, it's not just a simple up and down and that's it. It molds to you.
Wow.
So just the actual comfort of the mammogram is so much better than what we had seen years previously.
Okay, that's good to hear.
Yeah.
I've never had a mammogram, but I can imagine, the
Yeah.
women that I love in my life, that's
Those little
I'm glad
things,
to hear that.
little
Right.
things have changed so much.
We actually have two questions from our viewers, and they're very good. How can community organizations schedule the mobile mammobus for a site visit?
Yes, so my manager, Jamie Kelly, is over the mobile mammography unit, and her contact number, which we can probably list somewhere online as well, but it's 779-8221 is her direct line, and she can be contacted. She helps to organize all of our mobile events. Anyone that has a request, she'll find out where you want her to go, the hours of operation. We go to some factories that have General Mills. I know we had recently had one there. USA at Washington Courthouse. We go to Real King and Waverly. We were just there recently as well. But there's a lot of factories that, I'm thinking also of Candlelight, there's a lot of women who work at these factories that are overtime. They're 50, 60 hours a week, working multiple shifts, and they don't get time off of work. And if they do, they've got a million other things to do
Right.
that don't typically schedule those screening mammograms. So our mobile mammography unit has been an absolute amazing technology for our advancement to offer to all of our patients, because women who didn't have time to get off of work can now come in, do their testing while they're on the clock, while they're at work. It's just a quick 10, 15-minute test. Maybe they're on their lunch break maybe, but just quickly get that done at the work site. And we've detected a lot of breast cancers because of this.
That's a good way to get rid of the barrier of time and
Yes.
travel.
Mhm.
Okay, great. So here's one. How common is breast cancer in men, and what are the symptoms?
Interesting. So, not as common as it is in women, for sure. There's typically a genetic component associated to that. How we were talking about the BRCA gene. It's actually BRCA2. There's a BRCA1 and a BRCA2, and one is more common to be in, BRCA1 and 2 are common in women, but for men, BRCA2 is what you typically see. There's also ethnicity behind that. Ashkenazi Jews tend to be more common, so they're at higher risk, right? So there are patients that we commonly screen, and so typically with men too, the symptoms are the same. Like it's pain, it's again being aware, looking at any lumps that may be slightly distorted, the coloration, all kinds of things that you would notice this is just not right. And they would go again to their primary care doctor, who would order very diagnostic, similar imaging to women. It's no different, truly.
Yeah, I've had 2 men that I've cared for who have had breast cancer, and we started with a diagnostic mammogram.
Yes. Yeah.
So that answered that question.
Yeah, for sure.
Okay. Anything else that you think people should know
So yes,
about breast
so
health?
just dense, like I thought it was a really good question that we kind of talked about beforehand that you kind of sent to us. Like, what is dense breast tissue? Like, women are like, how do I know if I have that or not, right? So like, super common. Greater than 50% of women have dense breast tissue, and it's just how fibroglandular your breast. And so you're like, okay, what does that word mean? So we know as women, we have glands, we have ducts, we have ligaments, we have tissue in our breasts, and some women have more than others. And so that's what makes one more dense than someone else who may be more fatty, because there's also fat, ideally, in breast tissue as well. So with the 3D or with just mammography in general, it's an X-ray. So patients' breast tissue that are more dense, it shows up more white, and therefore it's more difficult to see. And that's why kind of transitioning to 3D universally is better, because most women have dense breasts, and most women don't want to have the scare of having a follow-up diagnostic imaging when we can just nip it in the bud with a really good or screening tool, such as the 3D. So.
Okay, yeah, I know that is a common finding on mammogram reports is you have dense breast tissue.
Yeah.
Absolutely.
And it's good to hear that it's common, and it's not common for that to generally cause cancer or be associated with increased risk, but making sure that if you do have dense breast tissue, that you're not skipping any mammograms.
Right.
So if there are any changes, they can be detected early.
For sure.
One of the things in Appalachia that I know is people who are diagnosed with cancers in Appalachia are typically diagnosed at later stages, and for multiple reasons: lack of access to screening, lack of awareness, and that's one of the reasons why we're here today, is to increase awareness. And then also just it's in the Appalachian culture to not seek medical care until there's a very obvious problem. And we certainly want our audience to know that we don't want you to wait. We do want you to get screened annually, or as you and your provider discuss and are comfortable with. It's very important to find and treat breast cancer at its earliest stages. We all have women that we love, and we all want them to be healthy. So if you're due for your mammogram, please get it. You don't need a physician's order or a nurse practitioner's order or a midwife's order. You can go to any Adena facility with an appointment and get your mammogram. And for those of you who work for companies or organizations who want the mammography bus to come out to your facility, Jamie Kelly is the director of that section in radiology. Her phone number is 740-779-8221. Did I get that number right?
That's correct. Yes.
Okay, great. So Jamie would be able to help you with a special event for your company. Well, thank you so very much. It's a very important month for healthcare to recognize that it's Breast Health Awareness Month, not just Breast Cancer Awareness Month, but Breast Health Awareness Month. And I certainly appreciate the three of you spending time with us today.
For sure.
Thank you so much.
All right. And we'll look forward to seeing you back here in 2 weeks for our next episode of Living Well with Adena. Thank you.